I'm going to, I know time's marching on, and so what I'm going to do is ask the speakers just to come up to these 4 hot seats, and we'll take any general questions or whatever, and we'll see how we go, and if it's 5 minutes, that's fine. If it's 15 minutes, that's fine, and so on. So if I'll just ask people to pop up.
Are there any risks with going cold turkey off your Nurofen Plus or Codeine Extra? I'm just thinking of people who may not want to divulge that they've been doing it and they want to do it on their own and withdraw.
So it's sudden cessation of opioids.
Yeah. Is there a risk?
It's very unpleasant.
Yeah.
And look, I think as as doctors and clinicians, we don't want to put people through unpleasantness, but it's not life-threatening unless you're a baby. Or unless, you precipitate withdrawal with naltrexone. People have been known to vomit and have diarrhoea so badly they become dehydrated and get renal failure. But no, it's not life-threatening, and plenty of people do it every day. But people relapse.
Do you use Codeine to assist with that?
Yeah. The thing is, Suboxone is such a well-tolerated, effective drug that clonodine's gone a bit out of fashion, but some people don't want to be on an opioid, even a partial agonist opioid, and we use clonidine. It tends to make people fall over, and so we tend to use it in inpatient residential detox settings. But for years it was the gold standard for managing withdrawal.
So someone on moderate dose codeine, can you go to low dose buprenorphine, or do you have to do a heroin dosing?
My experience is just the drug doesn't matter. And the dose of the drug, if you're dependent, doesn't matter too much. So yes, you can use heroin dose. You use the dose that manages symptoms, and sometimes people are heroin dependent. Symptoms managed on quite a low dose of Suboxone, and people who are mediocre opioid like codeine need quite a high dose. So.
Matt, can I ask?
The rates of relapse in people who do drugs detox or withdrawal, do they tend to relapse?
Yeah. So the problem is the trouble is those rates of relapse are of concern because it's mainly data that's collected from heroin users, and heroin users that relapse tend to die. And with codeine off the market, it's hard to relapse to that opioid of choice. And if you did, I don't think the risk is high. Dying is injecting a huge bolus of heroin.
So just want to put this in perspective. If I have people come in and they say, look, I take 15 a day of Nurofen Plus, those patients would pretty well say, look, that's fine. If you've got cold turkey, you won't feel very well, won't kill you. I guess the thing is with people coming in, they take 50. Or, at what sort of level would you say this is a concerning addiction that would need? Because the worry is you're going to have people who say, I don't want to take Suboxone, and I don't want to go and have my fibrous taken and go to the chemist, and they're going to say, no, I'm not going to do that, but I don't want to go cold turkey. And of course, we can still say, well, that's bad luck. But the issue is the patient does need to agree to follow the protocol. So my question is, which patients should we be really worried about? And which ones can we say, look, if you don't take anything, that's fine, you're not going to feel well. And also my other question is, I'm sure people are going to come and say, can I just have a bit of Valium? Can I just take a bit of Valium until I get over my addiction? And they're going to be very difficult to get off the Valium. So they're not people I'd want to be putting on Valium in this situation. I mean, obviously when people are detoxing from alcohol and stuff and we're monitoring them very closely and things like that, those types of patients, sometimes that's quite appropriate. But I think I'm worried about these sort of transient people who walk in and can become the patients who are going to give us lots of grief, very demanding, difficult patients harassing us. And that's what we're trying to protect ourselves against, I guess.
I think it's difficult to say what the cut-off level for treatment is. So if I've had calls to DACUS when people say, I'm taking 8 Panadine a day. I've got patients taking 8 Panadine a day. What dose of Suboxone should I put them on? So, that to me, if somebody's taking the therapeutic dose range of codeine, they probably don't need a pharmacotherapy. I mean, it'd be more comfortable. They wouldn't be symptomatic if they did. But I think you're making somebody more dependent than they are. So it's difficult to say a cut-off point. Then if somebody comes in and says, I've got symptoms and, I'm finding myself drinking too much or seeking other opioids to manage my symptoms, and they're taking above the daily dose of codeine, in terms of, it seems like a high dose, because the daily dose of codeine is different in a Panadol Forte than it is in a Nurofen Plus, of course. So if they've got symptoms and the dose seems significant, then I think then Suboxone is justified. But it's hard to say a cut-off dose. That's something you'd ring DACUS about, and I think that's a very reasonable question. Look, this is how many codeine they've been taking. Is that an indication for a pharmacotherapy? The second question is, the response. Opioid withdrawals is time limited, a bit like alcohol withdrawals. So if you're going to use, you can use benzodiazepines, but like alcohol withdrawal, you really contain it to a very short time, and there's not much evidence that they do any good, by the way.
And can I just raise about the underlying reason why they might have developed a dependency in the first place is that they might be managing an anxiety disorder or post-traumatic stress disorder. So that probably needs to be addressed too without cutting them off, so that then you do end up with that relapse or turning to something else to manage those symptoms.
I guess it's more just the patient coming in and saying, I'm desperate, I take all these tablets every day, and now I've got none, what am I going to do? And the issue is not wanting to say, they're just saying you need to taper it down. Is a bit of an issue. You might take it down with a patient you know. And I've definitely taken it down with patients who I know who have been on sort of ridiculous amounts of Nurofen Plus. Patients who are known to us that we can sort of work with and have been very successful. But for these sort of, I'm worried more about those patients who don't know, and you don't quite know. The real-time monitoring will be fantastic too, because you don't know if they're going to every doctor in the block saying, I'm coming off my 50 Codeine 4, or whatever, Nurofen Plus, can you give me enough to tide me over, and then they end up getting more.
The other side of the real-time monitoring is you might get those same people turning up at your doorstep saying, since real-time monitoring, my regular doctors refuse to prescribe narcotics to me. Can you do it?
No, I'm going to say bad, right, Carol? You've got far too many of these. That's fine. I don't think there's any problem about saying no when you think people are using things. But it's when you don't know the whole story is the difficulty. And when they're saying, but I take 50 of these a day, you can't just expect them to go home, which is why that's a great question. If we do say, well, sorry, we're not going to prescribe this because it's not a good idea, it's in the best interest, blah, 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 they're not going to die. We're not going to make our patients die, is what we really want to know. I guess we need reassurance about it.
Well, Malcolm like to answer the question. It might be more his age. Perhaps tapering the dosage a little bit and pulling out all the other stops.
So I suppose it's my experience that most GPs know their patients. So if you don't know your patient, you don't have that background, then I would be concerned about taking that patient on. You can give them a 24-hour, say, I've got 6 minutes or however much, but the MBS is willing to pay you. Then you say, right, I want you coming back tomorrow, in 3 days' time, in 7 days' time, I'm going to engage you in a process. I'll give you 24 hours if need be, bring the dose down. I use Codeine to treat their anxiety and withdrawal, and in that week period, I've got the nurse chasing up, who's your past GP, ring the DPU, find out the story. And if they're not on the ball, they'll soon move on and you'll be off the hook. But if they're saying, yes, I'm legit, I've been in the community, self-treating myself, that's your opportunity to engage the patient and say, I'm going to take a proper history, I'm going to look into your anxiety, stress, physiological aspect, what is true pain, because a lot of these people have got pain, but each time they get run away and stuff, they get injured, so they do have pain and addiction and anxiety, and you're going to untangle them and manage them separately in that process. So that's my experience with good GPs. My problem is they've got their allocation of time and they have to do regular bookings. They're booked up. So engage with someone else in your group to do some of the work for you, but you can then get them onto something. I personally don't have a big problem if you're skilled and experienced giving an opioid, prescription opioid, to someone who you think's got both pain and addiction issues. But you're going to take a risk, you're going to consent them, you're going to go dose limitation, 2-day pickups from the pharmacy, etc., to keep control.
I think there's doctors who are very want to help now, and it's took us 6 minutes to do it in a standard GP consultation. And I think this condition didn't come on overnight. It's not going to kill them. It's very reasonable, and somebody you don't know well to kind of take your time with it. It's not a medical emergency.
things seem to be flagging a bit. So I might stimulate things. I'm John McKenzie, Monash 1974 medical graduate, and I've had a lifetime of 43 years in at the coalface in rural general practice. I put that I was coming to this meeting to my colleagues on an email list, and they've got lots of things to sort of say I should bring up. So don't blame them. But thank you, Matthew, for that the Suboxone. That's been very, very helpful. Some of the things that they've said is, look, it's all evidence-based medicine these days. You know, we need the evidence for why we do things. But what happened to evidence-based policy? Now, I know KPMG are good, but if I was going to test a medical treatment, I wouldn't ask KPMG to ask a few people what they think. And that's what we've done with this policy.
I disagree there. What KPMG did was look at the economic impacts. The decision had absolutely nothing to do with KPMG's running of the numbers. The decision was about benefits and harms.
What I'd like to see, instead of, or what my colleagues would like to see, instead of bringing this in for all of Australia, where we, you know, it's going to impact on the whole Australia, why not take a little closed community like King Island, where you've got 1,500 people, one pharmacy, one little general practice, and introduce it there and see what impact it has, and then we'd have some real evidence. Now, we are worried about the fact that we may not be inundated in terms of numbers of patients, but these are going to be heart-simple consultations. That's what we're worried about. And it's going to really impact on the rural GP, you know, in a major way, because, you know, often we get 25 to 50-year-old males coming in wanting OxyContin, and they can be very, very intimidating in a one-on-one consultation. So we're a little bit worried about that, and maybe codeine goes to, you know, becomes a bit of a black market item. So that's why my colleagues have suggested, why didn't we bring it in just a small community first, which is closed, and see what happens?
They're actually, well, just to answer that question, I'll give a bureaucratic answer. There's very little power to be able to take a little part of Australia, whether it be Tasmania or King Island, and have a different medicine scheduling situation just for that little island. So actually, there wasn't the legal power to be able to do that for a small island. But I guess, you know, I do want to take issue with the comment about KPMG. They had absolutely no impact on the decision being written. The decision was based on evidence of morbidity and mortality versus evidence of benefit, or frankly lack of evidence of benefit. And we've seen the number needed to treat. It was not, from the 95% confidence intervals, it was not statistically different, significantly different. Paracetamol alone versus paracetamol and codeine in that number needed to treat. So it was a drug that had very little efficacy in the majority of people, and significant evidence of both morbidity and mortality. And that was what went out to the view of the expert committee. And remember, I mentioned we went to two separate committees 3 times, and the committees were unanimous in their view. It was quite unusual. Normally you get committees, 2/3 might feel one way, 1/3 might feel another. And these were both rural and city-based GPs, specialists, pharmacists, and health policy makers.
I'll pass those comments on.
Yeah.
But there were 2 other little comments they had, and that was, we find that our patients, when they go along to the accident emergency department at hospitals, they just get doled out Endo, you know, like Smarties.
Yep.
And we find that that's a problem. And just the other problem is, and I think Malcolm's the exception here, but in the earlier days of pain clinics, not so bad more recently, and certainly doesn't apply to Malcolm, we found referring patients to pain clinics, all it was doing was they were just getting prescribed opioids. I know this isn't Malcolm's way, and I think the pain clinics have improved more recently, but I just make those comments.
I consulted only one session a fortnight at Caulfield pain clinic, and that clinic is the Get People Off Opioids clinic.
I'm a bit more pragmatic because we deal with a lot of the lower socioeconomic, and our themes are actually optimise or minimise the harm, optimise the benefit. And so, from a pragmatic point of view, we just want to get the top doses down and get the risk managed and support their community care. The heart sync concept I hear, and in reflection, there's a reason. Those patients, there's a reason they've got to that point. And that's why I go back to my model of, who is the person? They've normally got some developmental aspect of trauma or stress or how they've managed to cope. And it's just how long have you got to weed that out. And I see a lot of iatrogenesis from surgery and other things and opioid prescribing where clearly the patient has an underlying distress level that has led them to being either addicted or psychiatrically unwell or surgically operated on multiple times or on opioids or cannabis using. Most people use cannabis for anxiety, not for euphoria. It's to manage their anxiety and their sleep disorder. So do you, as a GP, in a typical 6-minute consultation, have the energy to say, I want to get to the bottom of this or not? That's very difficult unless you know them and they're willing to engage with them. And it's not just the GP that needs to do it. It needs to be, I think, society, educating school kids about resilience and having processes in place in that period. It's not just going to be up to a GP treating a 50-year-old high-dose opioids. Again, that's my perspective. That's based on 20 years of seeing this sort of character. Yeah.
I'm a psychologist at Western Health and Sunshine Hospital, and I grew up in Latrobe Valley, and we worked with a predominantly disadvantaged population. And I guess my overall comment is, given how much psychology is played into development of chronic pain, that there really needs to be a bigger investment in psychological services, which I just don't see happening despite constant lobbying. One thing I did want to highlight to some of the rural and remote practitioners is that recently, as of 1st of November, there is telehealth available for psychological services. But it's similar to the issue that you pointed out, Malcolm, with the gap, that it's not enough necessarily to cover the costs of practice, and our clients can't afford the gap. So they miss out, and they rely on medication to cope.
Yeah, and this is partly where you've got to use all your other staff and be innovative in your model of care and know that you're not giving perfect, gold care, but you're getting 3 or 4 sessions of psychology with a nurse practitioner to do the extra education, to do the extra care and the phone calls and the support program. But yeah, difficult.
Any more on a long night? Oops, we've got one up the back, please.
Just a very simple question, actually. We noticed there was some real-time monitoring mentioned in one of the slides. How much emphasis is being given to that real-time monitoring?
So the system in Victoria will be mandatory, meaning all it will be captured, and it's primarily going to be captured at the dispensing level because 95% of dispensing is now electronic, whereas only about 75 to 80% of prescriptions are electronic. The goal will be to link into the electronic systems, so it will happen automatically, and you will just get a thing to say, this person's registered, this is what their last prescription was. So now,
just a question. I don't know how many of you are aware that as pharmacists we've been doing this for quite a while now, and why has that not been emphasized a lot more in trying to control this problem? Because we're finding that we're coming at the back end of a situation where we were already trying to perform our duties to do what we could at a community level, but it seems like it's almost been ignored, where now it's being used or trumped up as one of the things that the government is actually trying to bring through.
Yeah.
Now we've had this with sugar, I'm sure you guys are aware. We've also been controlling it over the last few years for Codeine as well.
Yeah.
And we believe we were in the forefront in trying to monitor and actually give some good feedback and data, which could have been much more useful than what we're going through right now.
So the Pharmacy Guild, who ran the Meds Assist program for Codeine, approached every state government. For it to have become mandatory, it would have been a decision of the individual state and territory governments, because they're the regulators of pharmacy, not the Commonwealth. Not one of the state or territory governments agreed to make Meds Assist mandatory. And so from the penetration data, it was about 70% of pharmacies were using it Australia-wide. In some regions it was 30%, in some regions it was 85%, but it was 70% Australia-wide. And there was significant evidence that it was getting known among people who wanted to buy multiple packs of codeine where they could go. And there were certain chains whose names I won't mention who were notorious for not having a system. And so it was a bit like having a sign saying, well, here's a map of Victoria. If you travel on these highways, there's never a speed camera breathalyzer, so do what you want. 30% of the roads. And so that problem led to the fact that it didn't really seem to manage the codeine issue, because unlike Project Stop, which was actually done as a pursuit-evergreen one, which was done as a law enforcement thing, not one of the states or territories agreed to make it mandatory.
My real question is, if it's mandatory now, why was it not made mandatory for us then? You know, we were all very happy to do.
So the whole government, every single government said no.
So now everybody's.
Only Victoria, so only Victorian government have initiated a mandatory system. It's not here yet, it's 12 months away. Yes, and that's prescription only, so it's not going to cover over-the-counter stuff. But eventually it will cover, as codeine goes to S4, it will be captured on this system because it's going to do S8s and selected S4.
Can I make another comment about Meds Assist as well? As a community pharmacist, my experience from using it not everyone was using it to best advantage, I guess. So some pharmacists were really diligent, some weren't. So some were recording it, ticking the box, but not necessarily doing anything with that information. I know sometimes when I looked up patients who were getting it multiple times, every couple of days, on and on and on, and there was no comments about what they'd done, what the pharmacists had done to manage that pain, no comments about whether there'd been referral, other things. So it wasn't actually being utilised to its best advantage anyway. It was rather tick the box, I can say, oh yeah, it's 3 days, that's reasonable, I'll give you another lot. Whereas it should have been used more about, okay, you're using this chronically, let's have a discussion about your pain management. And that wasn't always done. And it's also really hard in a pharmacy to have a conversation about potential dependence. In a 2-minute consult, you've got 10 people looking at you going, where's my script? The phone's ringing, the pharmacy assistants are going, I need help here. And you're trying to have a conversation with someone about potential dependency issue in sometimes not always an entirely private area, so that can be an issue as well.
Just to take one further from the comment earlier, is that this won't just be what's happening electronically. The option there will be GPs can look it up. So if you've got a patient presenting for codeine, you can look them up on the system and you will have access, which is where the doctor shopping hotline fell down and a lot of other programs fell down, and the New South Wales Tasmanian project fell down as well, because it wasn't mandatory and people went around it, and there was no flow-on effect. The GPs are never empowered to say, I can use this tool to change my prescribing practice and engage the patient with managing their pain or their opioid addiction.
Exactly, it's designed to be used as a clinical tool, not a policing tool. So it's a clinical decision tool, not something to say, no, yes, you can stop, or yes, you can go. It's about having that clinical information.
Just a question about in pharmacy, we'll have a lot of people come in for codeine, and so where does the patient go, the one that doesn't have a regular doctor, they've been using it for a long time for their headaches or their migraine or their back pain, and then if they go to a doctor, like she said, the doctor they said before, they're not prepared to treat this person that they have no history of, and then they just get handballed over and over and over. Like, where in a pharmacy can we recommend them to? Because there's the pain clinics, but they need a referral and things like that, but quite often they'll struggle to find a GP that will help them. And in the pharmacy, we'll get the aggro, the angry, like, give me my medicine, I've got a script for this, or whatever it is. Like, what do we do? Like, what's the best advice?
Can I say that under Annie was talking about the area networks, we can give you some details. Whereabouts do you live? Sunshine. Okay, well, Janet here can assist you. There are, if the individual can't find a GP to establish a report to get help, then there might be a referral pathway to drug and alcohol.
And also there's been some drug and alcohol funding for different services. So I think it's Noise Ariana that has the medicine.
Yep, so in the Eastern region there's the Medication Support and Recovery Service, which is funded by the Eastern Melbourne PHN. And that is a little bit like an alcohol and drug service, but it's actually more specific for pharmaceutical misuse and dependence. So it's designed to be a little bit, to make patients feel a little more comfortable in accessing a service like that.
And in Western Australia we have brief interventions, which is 5 counselling services with a clinician for people that potentially may be dependent or potentially people who, to prevent them from developing dependency as well. So, I mean, there's different areas have different services. And it might be about contacting your local PHN perhaps and seeing what services they offer in the area.
There's work going on at the moment to say we're going to have health pathways for addiction, psychiatry and pain, and that those pathways are going to be accessible to both pharmacists and GPs. And they'll all be region specific but reasonably consistent.
And have referral, where to refer to.
And then the government are going to have to respond, because the Sunshine, you might say, well, I've sent them to Western, I'm getting nowhere. Then the government will be monitoring this and then saying, right, we need to improve the services at Sunshine. If they can't do it, then we're going to take some of those patients and refer them into another service on their behalf.
We also have to regulate the individual too. They'll always find a doctor. They might have to travel a couple of suburbs, but if they want a doctor who is experienced in this area, they can usually find one within 24 hours.
In 2014, I believe, Medicare Locals funded Michael Nicholas to run a series of trainings for general practitioners, allied health practitioners and nurse practitioners across Australia. And they were aimed at equipping practitioners to be able to manage chronic pain patients locally, with the philosophy being that patients be treated in their local environment and referred to the pain clinics and pain specialists as a second line measure. We also have a situation where we have the Master of Pain Medicine with a parallel program, Master of Science in Pain Management, running out of Sydney University. We have the Masters in Pain Management or something similar running out of the University of, I believe it's the University of South Australia, it might be Flinders University, it's where Lorimer Moseley is based. There's the online program in the University of Otago, which Bronnie Lennox-Thompson coordinates. Is there anything that can be done to increase referral to people who've gone through those programs? Because it seems there are resources out there in the community that are skilled in managing pain, chronic pain presentations from a biopsychosocial perspective. Practitioners who do regularly spend not 15 minutes with their patients, but an hour and a half in some cases. And it seems that those processes, now diversity of practitioners, working in partnership with people like yourself, might be able to help some.
Yes, and that's what I suppose the model there was about, was facilitating greater service delivery at the community level, empowering the local communities to provide that. And Medicare Locals did it a bit better than maybe Medicare Networks, because they identified what was important in that area, whether it was mental health, hepatology, pain, whatever, and then they had funding for those programs. That's been dropped away a little bit more. It's now back down to GPs to empower themselves and say this is a clinical issue. GP champions will be part of the monitoring system. There will be champions placed in most of the networks. There will be pathways through the networks facilitated. And then, as I mentioned, there's all these resources. Some of it's going to have to be driven by GPs. So I'm going to go and spend the $360 to do better pain management, or I'm going to spend $5,000 to do a master's. And it's not going to come via a funding grant that we got from Tangible Percent, which initiated that round.
No, I mean, I recognise that's what I'm saying. There are resources out there to fill people up.
Yeah.
There's the I think it was you put the resource up for the College of, and it's the joint. Is it ROCG people? No, it's pain management.
My concern is what I'm hearing, heart sick patients. It's easy for me not to prescribe. I can put up a sign there, we do not prescribe opioids at this practice. Great. go and see a chronic pain patient. Fantastic. So it's easier to say no as a good GP, I suppose, than to really engage this cohort. And that's my worry. When I hear you talk, that's my concern.
But is there a conversation that needs to happen between this group and the NDIS? Because there's potential pathways through the NDIS to fund other services for these types of patients, because they're patients that are not working, and a lot of the patients that I see, some of them are chronic disability
Yes,
patients.
and they have the NDIS. That's a good point. I've never pursued it, and I'm not sure if we are recognised like a pain program and a transport to do a pain program. You get that on NDIS, but it's potentially possible. Yes.
So can I make just 2 points on that? Firstly, your earlier comment with regards to enabling and providing the resources, pointing GPs and health practitioners to the right resources, the right other support for pain management. A lot of the funding and the support that I said the government's providing to those groups is to actually provide that education and that information to provide the support in regards to where else can we go. And some of the other stuff that you mentioned with regards to resources and availability. In regards to NDIS, it's a good point. One of the things the department role that we've taken is how do we coordinate communications? How do we get the right groups involved in this? So I'll take that back and we'll look at how we engage more broadly through NDIS.
Perhaps if I can have a conversation with you.
Yep, I'm happy to talk to you after this.
Right.
Also, some of the regions are looking to, they've got funding and they're going to look into the ECHO project, which was done over in the USA, and bring that perhaps over to some regional areas here in Victoria for addiction and then hopefully pain. And that's about an online system where you discuss cases with experts and upskill GPs to manage these cases. And that's a bit of a short version, but that's something that they're looking to bring into regional areas as well.
Well, at one stage I thought everyone was going to peter out at 8:30. It's after 9. So I will try to bring things to a halt. I just want to, on behalf of the Department of Health, I just want to thank Penny and Malcolm and Matthew for contributing your evening. We've just been so lucky to draw on your significant experience and expertise in the area, and many of you who came along tonight have also shared pretty well. If there are questions or issues, follow-up. Avi, can we use the same RSVP address that we used if anyone has particular questions or colleagues have texted in or emailed in questions or issues and so forth? Or if you have suggestions, hey, you guys have forgotten all about this idea. So if you could use the same RSVP address, we'll pick up on that. I mean, clearly it's not an online consulting service, but there might be, even though we have spent ever since this decision was made, we've spent the last almost 12 months working very closely with who we believe are some of the best consumer groups, GP groups, specialist groups, nurses and pharmacy groups. I'm sure that there's things that none of us in our collective wisdom have remembered. So please don't hesitate to come forward with ideas, suggestions and resources. We don't have to reinvent the wheel, and as the point's been made, pointing people to resources. So look, on behalf of the department, I just wanted to thank you for coming along. This isn't a brainwashing program. It's a program of communication, education, and perhaps using this as a catalyst to focus our attention on some of the other areas, such as the strong opioids and the issue of how do we manage pain in the community when it's an increasing issue. I mean, some people have said we've actually got a pain epidemic, not an opioid epidemic, and while that I'm sure could be debated for most of the night, it's a point worth reflecting on. So thanks again for coming and for your time in the evening.